Hello, everyone. My name is Michelle Petri. I'm from Johns Hopkins. And today, for Room Now, I want to discuss how much we need new treatments for SLE. In particular, we need them for the very common non-renal lupus manifestations. And I wanted to emphasize how much we need new treatments for joints, because in every single clinic, I'm giving triamcinolone injections for joint flares. I think many of you know that I don't ever increase oral prednisone because I'm too worried about long-term steroid side effects. But I do give triamcinolone 100 milligrams IM for non-renal flares. So I wanted to discuss this abstract, it's abstract 1117, to show the hope, but also the potential pitfalls as new medications are developed for lupus. And this abstract is about Deucravacitinib. I think we should limit everything to 4 syllables, which is an allosteric TYK2 inhibitor. This is not the first time you've heard about it. It was also presented at EULAR. So where are we now for skin and joints? For skin, of course, we're going to start out with hydroxychloroquine, and then we're going to add methotrexate, mycophenolate, or azathioprine. If it's discoid lupus, our dermatology colleagues may consider drugs in the thalidomide family. And then when we turn to biologics, we have 2 choices, belimumab or anifrolumab. For joints, again, we start out with hydroxychloroquine, then we add methotrexate or azathioprine. We try very hard not to give anti-TNF unless it's a lupus, a true overlap, because we're so concerned about anti-TNFs not just causing lupus, but increasing lupus antibodies like antiphospholipid and anti-DNA. And then for biologics, we have belimumab, although many of us use other things off-label, don't we? So what might the TYK2 inhibitor add? Well, many early studies, think of them like phase 1, some of them were investigator-initiated, showed benefit of JAK inhibitors. So then what happened with baricitinib was very disappointing because in the phase 2 trial, it did show benefit for joints, but only one of the 2 phase 3s had positive results, it was for joints. But in particular, a TYK2 inhibitor might be safer than a JAK inhibitor because we don't like the JAK inhibitor boxed warnings in our lupus patients because lupus patients already have a propensity for those problems like thrombosis and malignancy. So I wanted to show you this summary of the key efficacy results, but then I'm going to hone down on some of the things I want you to see, because they're super important as we compare and contrast lupus trials going forward. So this trial is quite complete in terms of its presenting all the important outcome measures. And, at a first look here, you're going to say, oh, this is a nicely positive trial. But I want you to think more carefully about what the results actually might mean. So first of all, they do show the results for individual organs. And I think that's key, and I think we should require that of all lupus trials. But do you see the big surprise? What organ is this good for? It's pretty obvious it's skin, isn't it? Because that's what the CLASSI result is all about. Look at that delta for CLASSI. Like this is an oh my God moment in lupus. Now look at the active joint count. You can see, of course, there's a problem. The lower dose worked better. It isn't that it evened off, right? The higher doses worked less well. And in fact, that medium dose, only has a 7% delta versus the standard of care. That's not very impressive, even given the fact that many lupus trials are not that impressive. So kind of like a problem, right? This is not going to be your go-to joint drug if these kinds of results held up in phase 3. Now, I'm very glad they put in LLDAS. You know that lupus low disease activity measure is my favorite outcome measure in the clinic because it requires that the disease activity be low and the prednisone be below 7.5. So you can see that about 36% of patients achieve this wonderful goal. But now again, remember how concerned I am by that drop off, that patients did much less well on the higher doses. So, a concern. Now let's look at SRI. Now, why look at SRI and, not look at BICLA? Well, of course, I don't mind if you look at both. But the advantage of the SRI is the only way to lose points on the SLE day is by that manifestation resolving. So this doesn't look at partial improvement. This looks at what I'm going to say is a very meaningful improvement. And you see that there is a very nice delta with the low dose. Now, the medium and the third dose are really the same, aren't they? 6 BID and 12 once a day. So we're not surprised that those two give the same answer, but you see, of course, it's less. And if we take that 44.9 for the 12 once a day, there's only a 10% delta versus the standard of care. And I think we are looking for more than that in lupus trials. Now, one problem this has is that it appears to be a skin drug, and skin only gets 2 points on the SLE day. Joints get 4. So that hurt this in the SRI analysis. Remember, I still think it's very impressive for skin. Now let's think about adverse events, because remember, that was one of the themes for today. The JAK inhibitors have adverse events that are seriously unwanted in lupus. But in the baricitinib phase 2 and phase 3s, there wasn't a signal for thrombosis, and they did let antiphospholipid positive patients in. So at least that particular worry was never realized in the clinical trial setting. But now all you have to do is look at the last 3 on this table. So you see there's no signal for malignancy, atherosclerotic cardiovascular events, or thrombosis. So that's all very good news, because, we need more skin drugs. This would be an easy thing to give, right? Because it's got an adverse event profile that I think you and your patients are going to be very willing to tolerate. So where have we come in this whirlwind tour of TYK1 versus JAK inhibitors? The TYK2 inhibitor is promising for skin. If this holds up in phase 3, this would be a very welcome addition. Now, this is not the first RCT in lupus to fail to show a nice dose response, meaning that the higher doses work better, but, maybe theoretically higher doses would have more toxicity. What on earth does this mean? Well, I think it means that when you give a higher dose, other immune pathways kick in that then negate some of the benefit. And I think this should worry everybody, because you got to be so sure that you pick the right dose, because there is what I'm going to call a narrow therapeutic window before you start to lose the benefit. Now, phase 2 success does not guarantee phase 3 success in lupus. We've seen that so many times. Why? Well, I think part of the problem is when you get to phase 3, the companies have to recruit many more sites. And some of those sites may not be facile with the physical exam that's necessary for lupus or for completing the instruments. I mean, come on, guys, it's a multi-organ disease. It's often hard for me to correctly assess it when I'm in the clinic. So some of the problems that might occur in joints is, I don't care about the total joint count. I only care about the joints that are typically involved in lupus. When you look at the person's hand, you want to see the valleys between the second and third MCPs. We know in the ultrasound studies, those are the joints that are involved in lupus. I don't want to hear what's happening in the knees, for example. That's usually going to be something else like osteoarthritis or AVN or even fibromyalgia tender points. So I really care that we change our trial designs, and I'm an advocate for an MRI rather than let the physician mess things up. Now, how could we have problems with skin? Well, if the lesion is old and scarred, like many discoid lesions are, it can be sometimes confuse. So I would like to have photographs adjudicated. But so far, I haven't been successful in changing the study designs of lupus clinical trials. But I just wanted you to understand the pitfalls and why, even though this seems to be so exquisitely positive for skin, we still need to see the phase 3 results. I want to thank you all for listening. I want to remind you that Room Now is there at the ACR, always there for you. Room Now is where all the action is. Thank you.